Hello there, Andrew Colsky with National Sleep Network, where we bring you a lot of evidence-based information about sleep, sleep therapy, sleep issues. Today we have Joshua Lennon. He is a physician. He is the sleep center director at the Neurology Clinic in Memphis, Tennessee, and he's going to be sharing a lot of inside information with us about insomnia and CPAP and obstructive sleep apnea and all the things that we have questions about. So, Dr. Lennon, welcome, and could you please introduce yourself?
Sure. Thank you so much for having me. I apologize about my voice. I'm fighting the early ends of a cold here. So I did my undergrad at the University of Miami in Florida, not Ohio. I stayed there for medical school. And then after medical school, I came here to Memphis, Tennessee. I did an internship in medicine. I did a residency in adult neurology, and then went right into a sleep medicine fellowship for pediatric and adult sleep medicine. And then there was a lot of opportunities here in Memphis. And so shortly thereafter, joined a group, opened up a sleep lab. I stayed on as an assistant professor at the University of Tennessee and have really been trying to develop a more comprehensive sleep center, more than just what I had exposure to as a trainee, but really trying to get 360 degrees of sleep identified and managed, and really become sort of the main tertiary center for sleep management within Western Tennessee and the Mid-South.
Fantastic, fantastic. Yeah, I'll start off and ask you to dispel the myth for us. When people hear sleep center, a lot of times they immediately think of people with wires coming out of them and all sorts of medical devices hooked to them. What really happens at a sleep center?
Yeah, so our our center is kind of a three-in-one. So we are a clinic, and so there's a check-in desk, a waiting room, there's little exam rooms, or where we have our encounters. We also have the sleep lab where we do primarily home studies, but we do a lot of in-lab studies as well. And so you walk in, it's same office building, but behind a door kind of looks like a weird hotel room inside, and with a queen size bed and a lot of wires on the wall and a little camera at the top. And then we also operate a medical equipment distribution service as well. And so we've got little weird mannequin heads featuring all different kinds of masks. We have little dummy demonstration devices for all the different ways that we can treat sleep apnea and other sleep conditions. But when somebody comes for a sleep study, it really kind of depends. Are we doing an in-lab study? Are we doing something that can be done at home? The home studies have actually gotten really simple and easy to use. We have one of the devices we use for home studies. It's a single sensor, not much bigger than your thumbnail, that sits on the tip of your finger, and it just wraps around with a little bit of medical tape, and that's the entire sleep study. There's another device that uses a little sticker that just sits on your chin. Gentlemen like you and I can't do that because it has to be direct on the skin, so there can't be any facial hair in between. But just based on like the movement of the jaw alone, we can determine if somebody's awake or asleep or deep sleep or REM sleep, and whether they have breathing disorders or not. And then we have another device that is sort of a typical home study, where there's a little thing that sticks into your nostrils. There's belts on your chest and belly. There's a big plastic box that everything is plugging into, and there's a thing around your finger to measure oxygen and your heart rate. And then when we do an in-lab study, it's like the latter, but with even more stuff. So there's more stuff on your face. There's a microphone that's taped to your neck. There's EKG stickers all over your chest. There's the same belts, the finger probe. We also put a bunch of nasty paste in your hair that is, easy to get out, but still kind of an annoyance. And then all of this is kind of running into what's called the head box. So everything is plugged into this one box that sort of sits on the bed frame, and that runs into a recording computer down the hallway, where a technologist who's there to kind of hook everything up for you is monitoring all the biosignals all night long. If something comes loose, they're going in there and fixing it. If they're there for a therapy study, they're adjusting the amount of therapy that somebody's getting overnight until we try to get things as optimally treated as possible. And then in the morning, they come and take things off. Generally, patients are asked to come around 9 o'clock or so. They get acclimated to the center. They change into their pajamas or nice, comfortable, loose-fitting clothes. We apply all the different sensors over them. We again let them kind of hang out for a little while, get acclimated, because it is weird to try to sleep in an office building in the middle of the night. And so we try to allow that to happen. It's even more challenging when we do studies on children. If they're there for a CPAP trial, they may also just kind of hang out with the mask on, just to help desensitize it a little bit. sometimes for as long as an hour or so, just to get adjusted to that sensation of the air flowing into their throat. And then, we have our lights out. So we ask them to lay down, we turn off the lights, and then we basically watch them sleep, and we correct any mistakes across the night. And we flip the lights on in the morning, typically no later than 6 a.m. Help them get cleaned up, take all this stuff off. They can go get changed. They ready to get on, out of there and on with their day, take a shower, go home, or go to work, or whatever needs to be done. And then all of that data that was just collected, which is, typically 6, 7, 8 hours out of, a couple dozen different sensors across the body. It's a lot to process and go through and score, and what's legitimate and what is artifact, and what's concerning, what's not concerning, what's scoreable and what's not. And then we kind of come up with an answer, and then it's usually within several days, hopefully not longer than a week or so after the study is done, that they'll be called with the results and say, this is what we found, this is what we need to do, and these are the next steps, and then go from there.
Fantastic. Wow. So it sounds like you have a really comprehensive system there, but I did not hear one particular word, and I want to make sure that I didn't miss it. You did not say the word needle. Are any needles used?
Not in our lab. There's some really interesting scientific data on sleep disorder breathing that does involve needles and a lot more invasive probing, but but in day-to-day clinical practice, that's not part of what we do. So when we're talking about breathing sensors, muscle sensors, or monitoring our brain waves, these are all little metal electrodes that are just placed on the skin. And then to keep them there, there's a little bit of paste that helps to conduct the signal. And then you take it off, and there's no mark there afterwards, as you just gotta kind of wipe it off. But we're not poking through the skin at all. We're not shoving anything down people's throats or any other orifices. And so everything is just surface only, and then it comes off really easily and wipes clean.
Fantastic. Okay.
So nothing painful.
Right.
It's awkward for sure, but nothing
Yes.
painful about a sleep study.
I just want to reiterate and make it super clear for those that are listening. If you're going in for your typical sleep study, there's no needles, there's nothing that pierces the skin, there's nothing that's placed inside your body. It's all just surface stuff through like a tape or an adhesive or something like that.
Exactly.
Fantastic. Okay, so that's sort of the first thing that takes away a lot of the stress and anxiety about a sleep study. So let me ask you, I want to kind of talk about insomnia for a bit, and then I want to talk about sleep apnea, and I want to talk about this new thing called COMISA. That's a strange word that maybe we haven't heard before. So let me start off by asking, in general, with the patients and things that you see in sleep medicine, what percentage of people deal with insomnia as at least part of their issues?
Right. So there's sort of insomnia as the medical diagnosis. We have strict criteria, whether it's from the DSM or from the scoring manual, diagnostic manual, and then there's insomnia as a symptom. And so generally, when people come to us, either they're forced by a bed partner, referred, or they voluntarily come, that most of them, probably at least 60% are coming with some complaint of insomnia. So specifically, we're talking about either a challenge falling asleep in the first place when you're intending to, a challenge staying asleep across the night when you're intending to, or a challenge waking up too earlier than you intended to in the morning, followed by some kind of consequence. Right. So if I get in bed at 10 o'clock and I can't fall asleep until midnight, I get out of bed at 8 o'clock in the morning, I feel chipper, I go about my day, I have no difficulty whatsoever. I'm just friendly with my coworkers, I'm getting straight A's in school, and I'm getting along with my friends and family, and everything's honky-dory. I go back to bed that night at 10 o'clock, and I sit there for 2 hours, and eventually I fall asleep at midnight. That's not insomnia, right? So there has to be some functional impairment related to this challenge with their sleep overnight. So it's not just about not falling asleep or not being able to stay asleep. It's either something has gone wrong, either noticeably as a direct result of that sleep impairment, or oftentimes it's sort of a hidden consequence that, yes, I know that I'm having this challenge or that challenge, or my blood pressure is this or that or whatever. And we don't necessarily recognize that has a direct and sometimes indirect link to our sleep difficulty at night. But that's really what makes insomnia is not just the sleep trouble, but causing some other dysfunction in their lives.
Got it. Okay. So can we kind of break insomnia down for a little bit in terms of historically, current, and future vision, in terms of what has been done in terms of treatment of actual, insomnia, diagnosed DSM insomnia. What was the past? Was anything done about it in the past? What is currently going on in the field? And where do you see the field headed for treatment of insomnia?
Yeah, so insomnia is kind of interesting because I think in medicine we try to look for particular biological mechanisms for whatever symptoms somebody is having. And so there's been a lot of investigation and probing. Is there something going on with their brain? Is it their heart rate is too high? What's going on that's causing somebody to have this difficulty? And it turns out it's probably thousands of different things, right? So really, we're just sort of getting the 10,000-foot view: is this person's not able to sleep when they want to? And the mechanism, it could be entirely different person to person because it could be multiple different things. So they say, okay, well, if someone's just having this trouble and we don't really know exactly why it's happening, we can't have a specific targeted intervention to say, let's knock out this receptor, let's activate this receptor or stimulate this or that. So instead, the old school approach was, well, if they are awake, just sedate them. And so whatever we have in our arsenal to sedate them, that's what we'll use. And so, sometimes, that's, over the counter like alcohol or anticholinergic or antihistamine medications, allergy drugs for the most part. In medicine, it's also typically prescriptions that are sedative hypnotics, as they're known, like benzodiazepines or the newer class of benzodiazepine receptor agonists. These are like your Ambien and Sonata type of medications. And so just trying to knock them out as much as possible. More recently, over the last decade or so, as we've kind of figured out different switches in the brain that help to control the mechanism of wakefulness versus the state of sleep, there's one kind of master switch that is involved there. And it goes by two different names, either orexin or hypocretin. And so, they discovered if you basically block this signal, you are essentially turning off all of the different transmitters in the brain that keep us awake. If you activate this signal, you basically turn on all these signals that keep the brain awake. And so if we block that signal at night, it helps somebody to basically go to sleep without the typical sedation effect that we get with a lot of the older sedatives. And so that class called DORAs, or dual orexin receptor antagonists, there's now 3 of these drugs that have come out over the last 9 years or so. That's sort of been pharmacologically sort of the cutting edge more recently. In terms of what else is in the pipeline or what's really interesting, there's a lot of I think appropriate interest in non-pharmacological treatments, and I'm really happy to talk about CBT-I and our behavioral interventions. But I think the cutting edge stuff is really what else can we do to a person, right? Rather than how can we help somebody fall asleep on their own, this is like what can we strap on or inject them with something to make them fall asleep. And so there are really interesting data coming out on everything from tonal changes, right? Something like binaural beats. There are neural stimulators. You put a little headband on somebody, you're sort of giving direct feedback, based on brainwave activity to stimulate them a little bit. There's not that this is really applicable to the bedroom, but there's transcranial magnetic stimulation that can be helpful for insomnia in some cases. And so they're trying to figure out, is there a way that we can do something to the body to make it fall asleep? In a very low tech version of this, it has to do with cooling. And so there are mattress covers that do this. There are temperature controlled beds, and there was actually an FDA approved medical device that was basically a big headband with a big tube attached to a cooling tank, and it would basically just flush really chilled water across the forehead. And because one of the physiological changes in the body as we're going from the wakeful state to the sleep state is, as we get closer to that, the core body temperature is really cooling down. And this evolutionarily has to do with the sun sets, and then over the next several hours, the surface temperature is cooling down, right? So as our bodies are cooling, we're naturally transitioning more towards that sleep state. So if we accelerate that or do that artificially by cooling different parts of the body, accelerating the heat loss, we can help manage that shift from wakefulness to sleep. So, I think there'll always be, gizmos and gadgets that are going to be, have some novel mechanism that may be really interesting. but they're not really, number one, they're not really ready for prime time. They're not really going to be helpful for the vast majority of people that suffer from these issues. No one wants to, if I'm having trouble sleeping, to put a big clunky thing all over my head or a new piece of hardware, these enormous costs to go along with these things. It's not necessarily a feasible solution that's going to be helpful in the long run. And so from the late 1970s and really started being published in the early 1980s and has really just gotten stronger since then, is this whole idea of cognitive behavioral therapy for insomnia. So taking the basic framework of CBT, that our thoughts and our actions and our emotional states are all influencing each other, how can we use that model, that approach, and apply it specifically to trouble falling asleep or staying asleep? And to be honest, CBT-I, CBT for insomnia, much more heavily borrows from the B than the C. So there's real overemphasis on the behavioral modifications that we can make to help somebody fall asleep. And unfortunately, I think a lot of times this, the cognitive portion is kind of an afterthought. But it really, for certain individuals, they really need a lot of behavioral intervention. For other ones, the behavior is great if they really need more of, cognitive therapy, relaxation strategies, because their behavior is actually really appropriate. But what CBT-I involves generally is helping people understand sort of the basics of sleep, which most of us don't understand. This is not something that's taught in medical school, and probably not in graduate school for counselors or psychologists either. What are the things that drive somebody to stay awake or drive them to stay asleep? And all the different ways that those can get hijacked by different things that happen to us or different things that we do across our wakeful hours that can make it really difficult to fall asleep or stay asleep. And so with that understanding, having an idea of what some of these interferences can be, how can we minimize that interference? And so we generally call that sleep hygiene, which I know it has is a very loaded term that most people probably despise. Right. But that's really is a core of it. And I think the trouble has been is that sleep hygiene advice, not implemented, but sleep hygiene advice has consistently been shown to not help insomnia. But if you look at individual aspects of sleep, of sleep hygiene, we're going to do this one thing in a controlled trial, then it really does make a big difference. But giving somebody a handout or pages of like, hey, don't smoke after this time or don't drink after this or caffeine this and blah blah blah, people are like, yeah, and it gets crumpled up in a drawer somewhere. That really doesn't help anybody at all. But that basic understanding of what's happening to their body and why they could be staying awake when they don't want to be, I think is really foundational. And then a lot of it is really monitoring. People starting to pay closer attention to their own behaviors in and around sleep. Mm-hmm. And the basis for this is really the sleep diary or sleep log. And the point is not just for the clinician to get data back about when you're falling asleep or whatever. And that's why we don't say, hey, you go out and buy the latest gadget to tell us how much sleep you're getting. It really has to do with having the individual paying attention, not to get overly obsessed with it, which is another problem, but to start paying attention to what are the things that are going on, what is my behavior, how is this impacting my sleep, and really just tracking it intentionally over a week or two, and then using that information to say, okay, this looks like the data that you're providing me confirms what you told me last week, which is that this looks pretty awful, right? This looks like you're suffering quite a bit. I can see the agitation and how little sleep you're getting despite providing yourself an adequate opportunity. So a lot of the behavioral part really involves saying, okay, if you got this window of opportunity you're giving yourself for when you get into bed and when you start your day in the morning, and out of that, on average, not on any one particular night, not on the worst night, not on your best night, but on average over an extended period of time, you're getting a lot less sleep than you are getting time in bed. And that mismatch is a source of a lot of frustration. And it is basically stretching out whatever sleep you do get, and that's making it ineffective. It's making it inefficient. And so one of the core tactics that we use in CBT-I is helping somebody better match the sleep they're already getting in terms of total duration and matching the opportunity to the actual sleep they're getting. So if somebody says, well, I'm in bed from 10 p.m. until 6 a.m. and on average, maybe I'm only getting 6 hours of sleep, Well, that means their efficiency, their sleep efficiency for that opportunity is only 75%, which you're basically wasting 2 hours a day. And people feel that. They feel that frustration, that they feel that agony. And so a very simple thing is, okay, if you're only getting 6 hours of sleep, why are you spending 8 hours? Right? So instead, let's just give you 6 hours of chance to fall asleep to help you better fill that opportunity with actual sleep. And it doesn't happen on the first night. It probably doesn't happen on the second night either. But consistently giving somebody that more limited window of opportunity for sleep, their body is better able to naturally fill that opportunity with actual sleep. Now, depending on how much sleep they're actually getting, it may not be enough biologically for them to really satisfy their sleep need. But that initial goal is not to say, okay, let's do this one thing and make sure that your sleep is perfect, and then we'll stop. Instead, it's let's just try to make better use of your time in the bed. Let's try to remove some of these opportunities for frustration and for suffering. And once we've done that, now let's start working on trying to achieve an adequate amount of sleep. And everyone's body is a little bit different in terms of what their sleep need is going to be. It's how active we are socially, physically, how much we're doing across the day, the substances that we're taking in or not taking in, our nutrition. There's a whole bunch of different things that will impact, what our sleep need is. And that sleep need is going to vary from one night to the next. If I'm really, really busy, people that go to Disney World and they're just, putting in 20,000 steps a day, they're crashing that night. But then they go back to work the next week and they're sitting down for 10 hours straight, they're probably not going to sleep as well that night. So our need is going to vary a lot. And so, having flexibility, I think, is going to be really key as well. But part of what we're trying to do is not to say, well, you have to have 8 hours, right? Because you might need 8, but you probably don't need 8. Maybe you really need 7 hours and 15 minutes. Maybe you need 7.5 hours. Maybe some days you need 6 hours and 45. Maybe some days you need 8.5. But it's probably not exactly 8 hours. And so trying to force yourself to sleep in that window is, again, part of the frustration that people are getting. So we really compress the amount of sleep they're getting within a smaller opportunity. And if that's insufficient, then we gradually expand that opportunity until we start to see their ability to fill that time in bed with sleep slipping away. So if we can get 95% sleep efficiency, and as we expand that time in bed, it drops down to 80% again. Well, now we know that we've gone too far. That's too much time in bed. And so we start to compress it a little bit again. And then we can find for that one particular person, not the 8-hour magical number that people are chasing, but instead something that's appropriate for them. On average, maybe you only need 7 hours and 20 minutes in bed. If you're getting 7.5 hours, it's too much, and you just end up twiddling your thumbs, staring at the ceiling, and you're just getting frustrated. So that's really the basics or the core of a lot of the behavioral stuff. And then the cognitive portion really comes into, when we're laying in bed, sometimes it is, the same anxieties we have all day long are just as present at night. Sometimes it's that I have no anxiety all day long, and then I get into bed and it's silent and no one is talking to me. And now for the first time all day long, after being around noise and other people, that now, there's a lot of chatter that I just can't stop. It's not necessarily aggravating. It's not necessarily, anxiety provoking, but it's incessant and I can't get it to stop. And so then we do things like turn on the TV or, turn on music or do something to try to, quiet, this voice in our head that we're uncomfortable with, because we haven't experienced that for the most part all day long, because there's been other distractions keeping us from even noticing that background chatter has been there in the first place. And so a lot of the work that we do, for the cognitive therapy is to try to help people, come to terms with that. There's a lot of sort of, ACT involved in sort of the acceptance of this inner voice. And there's a lot of work to be done on, relaxation strategies as well. That what can we do to not just physically relax the body and prepare it for sleep, but to sort of help to relax the mind as well. So that, if there is some anxious chatter, how can we get that more down to sort of banal chatter instead? That's not quite as aggravating, to allow people to have that space to be able to fall asleep without feeling like they've got to keep on listening to whatever that voice is.
So that's a really comprehensive explanation. I really appreciate that, because that really kind of lays out exactly what these strange letters CBT-I mean. But let me ask you this question. So let me make sure I get this right, and then I have a follow-up question, which is, so early days of sleep medicine, we had medicine, pills, things like that would basically try to knock a person out. Then today's, culture or today's treatments, we're adding in or maybe supplementing or changing over to CBT-I, which is more of that cognitive behavioral approach, mostly behavioral, as you say. And I know based on the data that I've read, there's a lot of very positive outcomes with CBT-I for people with insomnia. But what do you say to the listener who might be thinking to themselves, well, wait a minute, sounds like that CBT-I is a lot of work, but this other stuff, I could just take a pill and knock myself out. Why wouldn't I just take a pill?
Yeah, it's a great question, and that's probably the biggest reason why, probably the second biggest reason why we don't see wider implementation of CBT-I. One, there's just not enough clinicians that have the background training and understanding to be able to perform it, which is why we have a whole bunch of different, everything from apps and courses and self-help books and everything else to try to provide wider distribution of those services. But I think the bigger reason why I say our documented success rate with CBT-I has kind of hit a ceiling of 88 to 90%, and it doesn't get better than that. And a lot has to do with the fact that we are asking somebody to change, and that's hard, right? So it's easy for me to recognize that something in my life is not going right because I'm not sleeping well. I can't fall asleep. I can't stay asleep across the night, and it makes me feel like there's something wrong with me, and I can recognize that. But the moment you ask me to change, it's like, well, I don't want to change because I like doing this behavior.
Right.
And sometimes it's easy to see the connection between my behaviors and actions and thoughts and how that's affecting my sleep. And sometimes it's not as easy to connect the dots there. But no matter what, there's always inertia, right? It's always a challenge to modify these things. And so adherence to recommendations tends to be less than optimal. And this is not a problem of CBT-I. This is a problem of humanity, right? This is the human condition. Is whether it's asthma medication or drugs to prevent a stroke or whatever it is that we have a hard time doing what somebody else tells us to do consistently unless we have some internal motivation to go on with that.
Right.
And so when we generally lay out here's what's involved and here's the outcomes and here's how well it's going to work and here's what you can expect to experience after going through generally a 6-week process of CBT-I, and a lot of people are like, no, no thanks, not for me. I'm not interested. I don't want to have to do anything. I just want to be able to sleep. Right. And so just knock me out, like whatever it takes, to be able to get to that point. And so that's certainly a challenge, right? Whether it's trying to manage somebody's anxiety, trying to manage their OCD, or trying to manage their insomnia, that a lot of times it's like, well, pill or no pill, these are the actions, behaviors, and thoughts that are contributing to your insomnia. And just because you don't remember what happened after you swallowed the pill doesn't mean that you're actually sleeping or getting the rest that you need and will be free from the consequences the next morning. And so there's a lot of salesmanship that goes into this. Some people, they kind of we're dragging them kicking and screaming into CBT-I. Other ones are begging for anything that's going to be helpful. But for the most part, it's just people that are hesitant. I recognize I'm suffering. I came to you trying to get some help, but what you're offering is not necessarily appealing to me. Right. Especially because you're asking me to do a lot of, I need you to fix this for me. I'm not here to do the work. I'm here to let you do the work on me for free. And that's difficult to get people to get them motivated to make those changes for sure.
Yeah. No, I hear you. And in my experience, and this is what I've learned, and please correct me if I'm wrong. Any of the sleep medications or sleep aids that people tend to take a pill, while they may knock you out for a certain amount of time, I think you said it in your answer there, it doesn't really provide true restful sleep. It just kind of knocks you out a little bit or a lot or whatever it may be. But being knocked out is not the same as getting true restful sleep. And, people who come to me for CBT-I, they're at a point where they want to do something. They don't like the current state that they're in. They don't like the fact that they're laying in bed and tossing and turning, whatever. And they, it's somewhat, they're coming to me because they've decided they want CBT-I. So I'm getting that audience. But the point is that it's so pleasing for me to start the process with them and then have them come back maybe the second, third week into the process and say, oh my God, that's the first time I've had a full night's sleep in years. It felt so good. And they're ready for that change. And so those are the people who are willing to make the behavioral changes. And then they see the results and it's like, oh my God, okay, well, this is what I need to be doing. So there is that aspect of it as well. But you're right. There's a lot of people who don't want to have to go through all the work.
Yeah, the mantra that we end up having to say a lot is, there's no such thing as a safe and effective sleeping pill. There's a lot of them that are really unsafe. The DORAs that have come out within the last decade seem to be relatively safe, but really not all that effective. If you look at an individual study or meta-analysis of all these different studies, randomized trials for these different sedative hypnotics, what you'll see is that, on placebo at baseline, it takes somebody about an hour, about 60 minutes or so on average to fall asleep. And when they take one of the pills, it takes them between 50 and 55 minutes to fall asleep. Right. So there's a reliably statistically significant difference between either baseline or placebo and the treatment arm. And so, we can say statistically, yes, there's a difference and this works. It's shortened the time to fall asleep and blah, blah, blah. And that's why we get, the FDA stamp of approval is not really whether this is, helping people in a meaningful sense, but whether we reached the milestone statistically.
Mm-hmm.
For the DORAs, what we tend to see is also a very limited, maybe they fall asleep 5 minutes faster than they did without it. Maybe the total amount of sleep they get across the day is really no different. The main difference between the DORAs and the traditional sedative hypnotics is the safety profile. And so the sedative hypnotics, we're primarily talking about activation of the benzodiazepine receptors within the brain, whether it's with a benzo directly or with the BZRAs, like Ambien and Sonata and Lunesta. And activation of this receptor in the brain, it does three things. One is it causes sedation. So it releases GABA, which is sort of a suppressing transmitter in the brain. So basically, when you activate that receptor, that tells every other brain cell around it basically to shut up and be quiet and stop being active at all. So it suppresses brain activity. The second thing it can do is, because of that suppression of brain activity, that it's an anxiolytic. So if someone's having a panic attack and then you basically knock them out, they're not having a panic attack anymore, right? So it's anxiolytic in that regard. And then the third thing, I should say that another thing that it does is reduce muscle tension, right? Because a lot of the regions of the brain are controlling bodily functions. And so when you basically stop all that activity or really, really shut it down, muscles lose tension and they start to relax. And so if somebody's having a seizure and they're convulsing, you could stop that convulsive behavior by suppressing that brain activity. And then the last and one of the most important features here is that activation of the benzodiazepine receptor, because it's suppressing brain function across the entire cerebral cortex, is that it stops the recording of ongoing memory. So it causes amnesia, right? So if you are getting a colonoscopy, that's not an experience you want to remember. And so we are constantly infusing one of these exact same drugs, typically something called midazolam, so that you might be like awake and like babbling about something, but you will not remember it because you don't want to remember that experience, right? But when you take one of these sleeping pills, the same thing is happening. So because I don't remember what happened, a few minutes after I took the pill until I woke up groggy the next morning, I assume I must have been asleep. Because I don't remember, I must have been asleep. And that is just, patently false. People end up still being awake because they're in this, interstate. They're not really asleep. They're not really awake. We have all sorts of unusual, odd behaviors that we call parasomnias that can take place. And this is why these drugs now have a black box label on them from the FDA, because people do everything from, texting, ex-girlfriends and boyfriends. They're online shopping, and so they're spending thousands of dollars on Walmart and Amazon that they didn't really expect to do. They're gambling online. They go and they're eating a bunch of stuff. Sometimes it's real food, and sometimes it's not edible things that they're consuming. They get out and they get in their cars and they drive. Okay, so this is what particularly led to the FDA black box warning: is that people were getting in their cars and crashing and killing themselves and killing other people. Wow. And then you have no recognition of this, right? So you have everything from murder cases that happen as a result of these agents to, really banal things that people get up and they mumble and they talk in their sleep and then they go right back to bed. But the point is they have no recognition of this, while it's happening, and they have no recollection of it the next morning because the substance they're putting in their body prevents them from remembering. And so, in one sense, it's like, okay, well, if part of why I'm suffering from my insomnia is that I'm constantly aware of my suffering, and if I don't remember, it's like a eternal sunshine of the spotless mind, right? If I don't remember suffering, is that therapeutic in some way? And I think there's a valid argument there. I don't agree with it, but I think there's an argument to be made there. But the consequences that we see of insomnia is not necessarily related to whether I'm satisfied with my sleep or not. It's primarily related to how much sleep am I actually getting. And so there is a serious physical risk of insomnia, primarily driven by how much sleep we're actually achieving, regardless of how we feel about that. Mm-hmm. And so there's an increased risk of death. There's an increased risk of cardiovascular disease. There's an increased risk of certain cancers, primarily driven by insufficient sleep achieved, not about whether I remember sleeping or not, or not about whether I remember suffering or not. While that certainly can cause next day consequences, the main thing that we worry about, at least on the medical side of insomnia management, is that are we increasing or decreasing this person's risk of serious adverse events? And with the sedative hypnotics, we're not achieving that. We're not achieving that decrease. If anything, we're increasing the risk of major physical harm by utilizing these agents.
Okay, well, that confirms for me what I have learned and believed all along, and I appreciate the explanation because it really helps to understand exactly what's going on. But you were talking there about the dangers of not getting restful sleep and everything related to that, which I think is a perfect time for us to talk about this strange word COMISA. Can you tell us what is a COMISA?
Yeah, and I'm blanking on the young man that coined this term. So in the world of sleep, for some reason I don't really fully understand why. Australia is the Mecca, right? So most of the brilliant things that come in the world of sleep come out of university and industry in Australia. And so it was an Australian grad student who first kind of coined this term. And COMISA is really for comorbid insomnia and sleep apnea. So COM for comorbid, I for insomnia, then SA for sleep apnea. So COMISA. And this is this combination of somebody who both has difficulty maintaining an open airway while they're sleeping, which has all sorts of physiological consequences. And either at the same time leading up to it or as a consequence of, they also have difficulty either falling asleep or staying asleep or waking up prematurely in the morning. And so, most people, that have sleep apnea can experience one of these things, but it's typically, that's not the main thing that bothers them, because a lot of people with sleep apnea might wake up repeatedly across the night. They get up and pee, they fluff their pillow, they roll over, but they kind of go right back to sleep. COMISA would be specifically, I wake up in the middle of the night, and my spouse says that I'm snorting and snoring, and I wake up and my heart is racing, I'm sweating a little bit. And then, it's taken me a good 20, 30, 40, 60 minutes to fall back asleep again. I finally get back to sleep. And the next thing I know, like my spouse is elbowing me to roll over because I'm making noise again. So then I wake up and my heart is racing and I'm like kind of wide awake and feeling kind of jacked in the middle of the night. And then it's another 20, 30, 40, 50, 60 minutes before I'm able to fall back asleep again. That is, something more like COMISA. Or, I have trouble falling asleep in the first place. I'm sitting in bed for 45 minutes, an hour, trying to fall asleep and not able to achieve that. And then someone along the line mentions that I snore. And so I sort of get funneled into a sleep study that I was really hesitant about doing in the first place. And they tell me that I have sleep apnea. Now I may have had trouble falling asleep, for 25 years, and I only started snoring 2 years ago. And so, the chicken and the egg doesn't really matter all that much in this regard. So sometimes it's discovered because of the symptoms. Sometimes it's discovered because of some other sign that a bed partner may be bringing to attention. But COMISA, it doesn't matter, what started what or what triggered what. It's really just these two things combined. Is there sleep disorder breathing, and is there some component of insomnia? Mm-hmm. And it turns out that compared to either condition alone, COMISA is just much worse. Right. It's worse in terms of next day effects, and it's worse in terms of overall cardiovascular risk. We don't have a lot of data to say, well, people are more risk for ADHD or depression or car crashes or whatever, because again, this has only been coined within the last several years. So there's limited data, on in terms of major adverse outcomes. But certainly what we see is that compared to those with insomnia alone with no sleep apnea, or compared to those with sleep apnea alone with no insomnia, the combination of these two together is much more deadly than either one by itself. And what we've also come to learn over the last several years is that, sometimes treating one or the other provides some benefit. Sometimes it can make it worse. But there's an order of operations that really matters. So if you take somebody who is a little bit more type A, who just has a little bit more of an anxious mind to begin with, and they're having trouble falling asleep, and then you say, hey, strap this contraption on your face all night long and breathe like Bane or Top Gun, and then hope that allows you to fall asleep, because at some point you're going to choke in the middle of the night. That tends not to make it much better, right? So they tend to have some of the lowest rates of use of CPAP among those with sleep apnea, high rates of discontinuation, and often their insomnia symptoms might get even worse because now we're adding one more thing to keep them awake, and so we can do more harm than good if we're not careful in how we address these things. There are certainly other individuals who, especially those that have more of a maintenance insomnia issue, no trouble falling asleep, but trouble staying asleep. They keep waking up across the night because they're not breathing effectively. So this is one of the body's safeguards. In order to not die from choking on our own throat, the body wakes itself up. And if it wakes itself up so violently that we're awake for an extended period of time across the night, then we can have insomnia, trouble getting back to sleep. But if we are using whatever treatment for sleep apnea that we're utilizing, CPAP is the gold standard, because we're not choking any longer, that initial trigger to wake up in the middle of the night is no longer there. So there are several people where if all you do is treat their sleep apnea, their maintenance insomnia may go away completely. But for the most part, what we tend to see is that which condition we're trying to tackle first really matters. And so the data shows us that if you try treating both simultaneously, or if you treat the sleep apnea first and then insomnia as an afterthought, people don't do as well. Their insomnia gets better, but not as better as it ought to. And their use of their CPAP tends to be lower than those where we're really tackling their insomnia first and foremost. We're most of the way through a program of CBT-I, and then we start addressing their sleep apnea. Not only is their insomnia overall better controlled or less symptomatic, but their adherence to and utilization of their CPAP, because these trials are all with CPAP specifically, is better than those where we treated both at the same time. Because we sort of their symptomatology is their insomnia, and so that's getting better by utilizing CBT-I techniques. We've got a little bit of buy-in. We've built some trust with them by saying, yes, you've got both these conditions, but rather than just like forcing you, because a lot of people, and I hear this all the time, they think that's all a scam, right? It's just a big scam to sell a CPAP machine, and that we're just ignoring everything else. And so by saying, no, I'm taking you seriously. Your chief complaint has been about trouble falling asleep and trouble staying asleep. So let's tackle that first and foremost. But we also can't ignore the elephant in the room. So eventually we're going to get to treating the sleep apnea. But if we go for the insomnia first, your main concern first, we're achieving wins, we're getting gains, we're getting better with that. And now we start saying, okay, now that you're sleeping better, now let's actually tackle this other major medical concern. We've gained their trust. They are sleeping better for the most part anyway, and so they're just overall more likely to utilize that intervention for their sleep apnea. And so now their overall risk is going to be better, their symptomatology is better, and their overall adherence to anything that we recommend is going to be better as well. So I think we on the medical side of sleep are zealous and aggressive about putting people on CPAP, not because it's a scam, but because that's essentially the only thing that we've been trained to do for the most part in sleep medicine. And that is great for some people, and it's a disservice for others. And so we need to be careful when people have the combination here of which thing we're really tackling first and foremost. That we can't just say CPAP, 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 and then because insomnia is not going to kill you as badly as your sleep apnea is, we got to tackle this thing first, and then the insomnia is kind of an afterthought. It really does matter. We really do have to address and mostly, if not fully cure that insomnia before we start trying to tackle the sleep apnea.
Wow. Yeah. So that, and that is such a common thing for people to have both of those issues. So when you talk about CPAP and when you talk about, sleep apnea, can you give us a better understanding whether they have insomnia or not? If someone has sleep apnea and they've been, given a CPAP machine and they choose not to use it, or they're having trouble using it and they're not treating their sleep apnea, what are the risks for someone who doesn't treat the apnea?
Yeah, so I think it's important to really understand what sleep apnea is. There's a misconception that sleep apnea is caused by weight gain, and that therefore any weight loss is going to fix the sleep apnea. Sleep apnea, we think there's sort of major contributors have to do with how collapsible the airway is, how easily our muscles respond to change in airflow that's starting to tighten up and open up again, how readily and rapidly the body recognizes when oxygen or CO2 is out of order, and how easily we wake up. So that we call those the endotypes, or the pathomechanism of sleep apnea. But fundamentally what's happening is when we fall asleep, muscles relax, right? So we kind of melt into the bed, right? All of our muscles, from the body tone and the shoulders, the back, the legs, everything is getting more relaxed. In the airway, the pipe starts at the Adam's apple, or the Eve's apple. But from the tip of the nose down to the trachea, it's just a potential space, right? So it's held open actively by muscle tension. And when those muscles relax, that airway is likely to start to collapse a little bit. And some of us, it collapses a lot of it. So the tongue is the major contributor, both to keeping everything open and for allowing it to collapse. So if the tongue relaxes too much, it starts to slide backwards to the back of the airway. The walls of the throat, the pharynx, which is inflamed in me right now, which is why my voice sounds terrible. The pharynx, those pharyngeal muscles can also relax, and they start caving in, from the sides and the front and the back. And then there's the palate, the soft palate, which is, hanging off the hard palate, off of a bone, but this is what vibrates and causes the noise of snoring. So that starts to relax and collapse down on top of the tongue. So we start to lose the space, the physical space that's allowing us to breathe. So whether that reduces by, say, 20% or 90%, we have some reduction in airflow. We have sensors throughout the airway that are keeping track of that airflow. We have sensors throughout the lung tissue, the carotid bodies, and the brainstem as well that are keeping track of our blood gases, oxygen and CO2 specifically. And when there's any error there, when flow is decreasing, when oxygen is dropping, when CO2 is increasing, the body recognizes that we're not breathing as effectively as we ought to. So it sends an alert. And this alert basically wakes up our brain. When our brain wakes up, we regain muscle tension. So the muscles of the upper airway regain their tension. So they open back up again. So now we have that physical space to breathe again. And oftentimes it's an overbreath, what we call a hyperpnea, right? So we're excessively breathing, we're hyperventilating to recover oxygen back up to normal, to get rid of all that excess CO2. And then we fall right back asleep. So that awakening, that arousal is typically 3, 5, 8 seconds long. It's so short, we're never consciously aware of it. Mm-hmm. Sometimes across the night, we have a more violent arousal. We wake up, we look around, and we have to be awake for minutes or sometimes hours across the night. But the vast majority of these events are so short that the brain is in the wakeful state just long enough to send that wakeful tension signal to the muscles to open the airway so we can take a few good breaths, and then we go right back to sleep. So the consequences that we see to this are really threefold. The first is this change in blood gases. So low oxygen is bad, right? That's what a heart attack is when it happens to your heart muscle. That's what a stroke is when it happens to your brain. You can get these infarctions or ischemic injuries, these lack of oxygen injuries to your gut, your liver, your pancreas, right? Your muscle tissue, anywhere in the body. Of the trillion cells in the human body, every single one of them, without exception, requires oxygen to live. And when you deprive that tissue of oxygen, it causes damage, oftentimes irreversible. And some of the most sensitive tissue in the body to these fluctuations in oxygen are the skin cells that line our blood vessels, called endothelial cells. And so the largest consequence that we see physically from sleep apnea is cardiovascular disease, because these skin cells that are lining all of our blood vessels, when they get injured from hypoxia, they start to stiffen, they don't relax it as easily. And when they get a little injury like that, it's easy for plaque to build up on them. And so then before you know it, a big wide open tube starts to become mostly closed off. And if that's your coronary, you end up with a heart attack, it can cause a stroke, kidney damage, all sorts of problems, because every organ is relying on the supply of blood that is now compromised because of the damage to these endothelial cells from that fluctuation in oxygen. The second hit which impacts a lot of people, is the fact that we have this alarm system. So while it is better to live than to die from choking, it comes at a cost. And so this arousal system is the sympathetic nervous system, or the fight or fight system. So the body literally floods with stress hormones like adrenaline and norepinephrine. And once they sort of percolate up and reach the cortex of your brain, it wakes up the brain. So when your brain's exposed to adrenaline, it wakes up, that sends a signal to your muscles, and so the muscles open up. But this arousal signal is universal. It's going everywhere. So it's not just waking up your brain and your airway muscles. It's going to your heart. So your heart rate increases and your blood pressure goes up. It's going to your kidneys and your liver and your pancreas, and they're conspiring to release more sugar into the bloodstream, because if you're in a fight or flight mode, you're going to need an energy source to run away or to fight somebody, and that energy source is going to be glucose or sugar. And so your liver has been storing sugar, for when we're fasting. Your pancreas is releasing insulin, and so in the middle of the night, when we're not about to go run away, we have these blood sugar spikes, and so we see all sorts of metabolic consequences from this constant arousal response. We see autonomic dysfunction, everything from POTS to anxiety and other dysfunction that can happen from this constant state of activating the sympathetic nervous system. Right? If somebody cuts you off in traffic and like you slam on your brakes and your heart is racing, like you start to feel the sweat happening, right? It's that response, but happening hundreds of times a night, right? Not like once in a blue moon when some jerk is pulling out in front of you, but right, over and over, dozens to hundreds of times every single night. And that's an enormous toll on the body, that level of activation of the sympathetic nervous system. And then the third proximal consequence here is the fact that your brain has to wake up to get you to start breathing again. So the whole body runs in a circadian 24-hour rhythm of activity and rest, but it's your brain that's doing the sleeping. And when your brain sleep has to stop so that you can wake up and activate these muscles so you can breathe, your brain is not happy, right? So everything your brain does, from our vision and our movement and our balance and our memory and our social interaction and short-term memory and emotional regulation, everything the brain does for the human body is relying on that brain getting the rest that it needs during the circadian night. And when that rest, that sleep is constantly interrupted, again, hundreds of times every single night, there are consequences to that. And so the most obvious is that people wake up and they don't feel rested. They might feel tired. They might doze off or fall asleep unintentionally during the daytime. But there's lots of other issues too. We see a doubling of the risk of depression among those with untreated sleep apnea. We see a tripling of the risk of anxiety among those with untreated sleep apnea. We see much higher rates of PTSD among those with untreated sleep apnea. We see the main mechanism for how we end up with these neurodegenerative conditions like Alzheimer's disease is dysfunction of sleep, of which sleep apnea plays a very, very large role. And so having that fragmentation of the normal sleep state is consequential for how the brain is able to operate during the daytime. And so everything that we see from sleep apnea is a result of one of these three proximal consequences: blood gas fluctuation, constant arousal, and then interruption of the normal sleep state. And so everything from major organ dysfunction to vascular disease and stroke and heart attacks to mood disorders are all related to one of these proximal things, because the body's always running this calculation: should I stay asleep, allow the airway to collapse and asphyxiate on my own tongue, or should I sacrifice and wake up and keep on living? And every single time it's going to choose to wake up and live.
Right.
There are the most conservative estimate that we have is that there's 1 billion people with a B, a billion people in the world that have sleep apnea. And out of all those individuals, it is a small handful that might die every year as a direct result of their untreated sleep apnea. So as a percentage, it's extremely small. People die all the time as a consequence of their sleep apnea, but usually as an indirect result from cancer or heart disease or stroke or dementia or all sorts of other issues, infection, falls, bone fractures that come as a consequence of sleep apnea. But for the most part, this arousal system is very effective at sacrificing sleep so that we can wake up and breathe and stay alive.
Mm-hmm. Wow. So this is a great video that I will be able to share with my patients when they need to hear a little bit more from an expert like yourself on the consequences of not, treating their apnea. And, we could go on for hours and hours with this, but I do have sort of one wrap up type of question, because I think we'd be remiss if we didn't answer it, which is, so we talked about sleep apnea, we talked about the dangers, we talked about the fact that there's this thing called the CPAP machine. Can you tell us, what is a CPAP machine? What does it do? Why do I need this hose sticking out of my head all night?
Yeah, so CPAP, again, thanks to the Australians. In the early 1980s, a guy literally in his garage took his vacuum cleaner, took the motor out, popped it in reverse, took the tubing out the back of his dryer, collapsed it, attached it to the vacuum cleaner. He had a friend who was a makeup artist in the Australian TV industry who made a plaster mold of his nose, and then basically attached these things together. So very, very rudimentary, but that is fundamentally still what a CPAP is today. It is a flow generator, something that's taking regular room air, spinning it through a fan, faster moving air exerts some pressure. It's passed through a conduit, a tube that's then attached to some mask that goes over the face to direct that airflow down the airway. So once it gets to the palate and to the tongue, it's able to hold that tissue in place and keep it from collapsing. We measure this flow, the pressure of this flow in a weird metric called centimeters of water. So if somebody has a CPAP machine that's set to 7 or 12 or whatever, we're basically talking about what is the weight of a column of water in a straw, that's 6 centimeters tall, right? So how hard do you have to blow in the straw to move that column of water up or down? So these are not enormous amounts of pressure. These are fractions of one atmosphere that we're utilizing, but we don't need a lot, right? This tissue is not dead, it's not paralyzed, it's relaxed. So it needs a little support to help keep it open. And the amount of pressure that it takes to do that is not so much that we can't actually exhale out against it. So it feels weird. It feels very strange to breathe out against that resistance, but it's definitely not impossible, right? And so the pressures we use for CPAP are typically about a third or so what we might often use in an ICU on a ventilator, right? When somebody has when we've literally paralyzed them and put them under sedation, under anesthesia, and allow the machine to breathe for them, that machine is using much larger pressure than we normally use for a home CPAP device. The main problem people have, because most people have a problem with it, is not the little piece of hardware on the bedside table. It's not the flow. It's not the air moving. It's the interface, right? Because it's so weird to sleep with something strapped all over your face, right? To have something that's wrapped around the back and it's pushing against your nose and it's blowing air into your eyes and it's whistling in your ear and making noise, and you constantly have to fiddle with it. And it is a pain in the butt a lot of times. And 2/3 of individuals that are started on CPAP are not using it within a year. Most people are avoiding the diagnosis of sleep apnea in the first place because they know they're not going to use these things. A lot of people do pretty well for the first several weeks in terms of giving it an honest, good try. And maybe a third or so have dropped out within 2 to 3 months. But then by a year, another third have dropped out. It's weird. It's hard to keep up with. It's a big ask of somebody, right? As we talked about earlier, like you want me to change. It's a lot easier for me to just swallow a pill every single night than to strap this thing on. And I got to add wine distilled water. Like that's expensive. I got to go to Sam's Club and get all that every day. And I got to clean this thing out and clean the mask. And it's a lot. It's too much for a lot of people. Mm-hmm. And so adherence to CPAP is abysmal. Right? It's really, really, really poor. Some people, they use it for the first night and their lives are literally changed. I see this all the time. I have a biased sample. There's a survival bias, right? The people that keep coming back are the people that are still using it, right? So we tend to see that bias. There's a lot of people that try for one night and they hate it. They hate the sensation. They hate the mask. We have a big problem on the medical side. One is not helping people to understand what it is that we found on a sleep study, why it's important to get it addressed, and the multitude of different ways we have of addressing that. CPAP is only one of them. And we have an industry problem where the devices themselves are not necessarily user-friendly. A lot of them are kind of clunky and difficult to use and to navigate. We have an industry that is hell-bent on selling you the most expensive mask possible, which is usually the larger, bulkier ones that tend to leak more, that tend to be more uncomfortable, that tend to disrupt normal breathing more than if it was nose only. and whose profit margin is larger than the gross cost of the smaller, more comfortable masks. People are much more likely to stop using a CPAP if they have a larger mask compared to a smaller one.
Mhm.
But there are weird profit incentives, and because across medicine, reimbursement keeps going down, right? So we've had this crazy several years of inflation going, as high as 9% year over year, and every single year, as inflation keeps going up, what your hospital, what your imaging center, what your dentist, and what your doctors and nurse practitioners are getting paid for the same service keeps going down year after year after year. And so it's hard to blame the industry for saying trying to stay afloat and keep the lights on by forcing people into these larger masks that have a larger profit margin, because if they don't, they're going to be out of business, and then no patient gets anything, right?
Right.
But that's a big problem, because they tend not to work as well as the smaller masks. They tend to leak more. We actually need higher pressures for those larger masks, because now most of the air we're pushing from the machine is hitting skin and not the airway. So it bounces back, it pushes the mask off the face, it causes more turbulence under the mask, which leads to more leak. We have more surface area of contact with the skin, allowing for more leak. And so they tend to drastically underperform compared to the smaller masks. So that's a big impediment as well. And then also people are not told that, yes, while CPAP is the gold standard, and I don't see that changing anytime soon, with all the things that are still in the pipeline, it's also the most cost effective. Medicare literally saves tens of thousands of dollars every year for every patient, Medicare recipient, who's using a CPAP. Okay, drastically cost saving, but it's not the only thing. There are other interventions that can treat sleep apnea, right? So when we think about, what is sleep apnea, what is it causing, approximately what are the consequences, what is most important is that somebody is breathing while they're sleeping, just like they breathe while they're awake. And there's lots of ways to do that. 50 years ago, we thought the only way was to cut a hole in somebody's throat. It worked really well, right? If you bypass all the tissue that's collapsing, you can help them breathe. But a trachea is complicated, to say the least. Within 20 years of them doing that for sleep apnea, we started just cutting out tissue from the throat, shaving off the palate, cutting away the base of the tongue, widening the walls of the pharynx by slicing off some of that tissue in the tonsils. And that helps some people and it harms some people. And then there are other surgeries that can do to help suspend the tongue. That can increase the potential space within the nasal cavity. We have CPAP. For the last 30-something years, we've had dental appliances that a very small number of qualified dentists are able to make. A lot of dentists will say they'll make it anyway, but they don't really know what they're doing. There are specific criteria for training that dentists should go through to manufacture and to adjust these devices. But they help to hold the jaw in a forward position, to keep the tongue held more forward. So when it does relax, there's more space behind it for the column of air to move in and out, for somebody to breathe effectively. There are stimulators that help to stimulate the tongue. One is used during the daytime to help improve the tension in the tongue. There's now one that's already FDA approved, and two that are really at the end of the pipeline, that while we sleep, stimulate the tongue and move the tongue forward out of the way to open up the airway. There are devices that use our exhaled breath using a valve system to open up the airway. There's a device that uses a negative force, a vacuum, to help to suck the tongue towards the teeth and hold it in place so that when we fall asleep, it's not collapsing backwards. So there's lots of ways that we can address sleep disorder breathing to help somebody breathe better and therefore live better. And I think we overemphasize and we just hammer CPAP, 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 CPAP. And yes, it's the gold standard. And yes, it works really, really well. And yes, it's really cheap comparatively, but it's not the only thing. And so instead of taking a CPAP-centric approach, I think what we're lacking in the sleep medicine field is a individual-centric approach. What is this person experiencing? What are they suffering from? What are their obstacles potentially to utilizing CPAP effectively? And how can we get around that to make sure that we're treating them, not just treating their airway, but treating the person, and finding an intervention that they can utilize, that they can afford, that can reduce their risk of all these adverse consequences from sleep apnea.
Right. Wow. That was great. I had not heard of many of the devices and options that you described there. So I definitely interested myself in looking up some of this and just learning about them. But it is it's such an important thing, though, that sleep apnea be treated, whether it be with a CPAP or some other way. But to just ignore it and hope that it's not going to bother you. Unfortunately, you listed the consequences for us, and that should really be an eye opener for people. So, you know, like I said, we could go on for hours, but I've taken a lot of your time already, and you've been so gracious to give us all of this wonderful information. I'd love to perhaps invite you back at a later date to dive deeper into a particular area, because there's just so much to learn here. But Dr. Lennon, thank you. I really appreciate your time. I'm so grateful that you joined me and you shared all this with the audience. I'm definitely going to be sharing this with my patients. And you know, thank you again.
It's my pleasure.